everybody. Thanks for
Well,
joining.
thanks.
Yeah. So I'll just get stuck in.
Yeah,
so
work away, Naomi.
I'm going to go first, and then I'm going to hand it over to Derek. So I'm just going to go through a few things quickly. In relation to it, and I suppose Migraine Ireland's interest in this topic and why it's close to our hearts. First thing being today actually is Cluster Headache Awareness Day, 21st of March. I'm going to go through some smoking information in relation to migraine, nicotine and headache, and just different supports that we have as well in relation to quitting. So a bit about me. Dee kind of went through it already, but yeah, my role is informational. I am a nurse, but not in the clinical sense at Migraine Ireland. I'm here. I just provide information and support services to members of the migraine community and their loved ones, as Dee said. So that's just kind of my role and where I'm coming from with this. So it's just, I suppose, important. I always say as well, just if something comes up for you tonight or ever really in relation to headache or anything else, just speak to your GP. And we can't offer clinical advice or this what's in the talk is purely informational. Yeah, and that's just important to bear in mind. So today, as said, is International Headache Awareness Day, Cluster Headache Awareness Day. Sorry, Cluster Headache Awareness Day. And so what's cluster headache? I just wanted to make a little bit of a reference to it, given the day that's in it, and to start off with. So it's one of the most painful conditions that is thought that can be experienced. It's quite rare. It's around 1 in 1,000 people experience, and it's more often experienced in men. Some of the characteristics include feeling a boring, piercing, burning pain on one side of your head. It can be quite random. It can be maybe in a pattern. It's different for everybody. Accompanied by the other symptoms there: watery eyes, blocked nose, and these are just general symptoms. It can be different for everybody. It's a tough thing to have diagnosed, and it's often experienced by it's experienced by smokers, disproportionately to the rest of the general public. And smoking is thought to be an aggravating factor in it. And from what we know, it's not fully understood. There's not much that's understood about it. It's like migraine as well and other headache conditions. There's a lot more research and studies that we need in order to tackle it and overcome it and give people the help that they need. But that's one thing that we just have, that one pattern that has emerged. So that's kind of why we thought, it might be important to provide a resource in Derek's knowledge and experience in relation to actually giving up smoking, if that's something that you have an interest in, or maybe you've tried before, or we just wanted to kind of provide people with a support and a resource for that if it's something that they're struggling with or interested in. So there's some websites there that are great. They're UK based, but they have amazing information as well. And there is a bit on our website as well, migraine.ie. Should probably put that in, but and then just if you have any concerns, that, as I said at the start, speak to your GP, and if you think something is immediate, go with the for any headache concerns. Okay, so this is some information in relation to migraine and smoking, and as I kind of touched on with cluster headache, not a lot of research. There's not a lot of study and evidence to go off really in relation to the relationship between migraine and smoking, and also other headache disorders and smoking as well. So so just go through a little bit about what we do know. So it does appear that smoking is more prevalent among people who live with migraine, and smoking and migraine are on their own. They're independently risk factors for stroke. So if you have migraine, that is a risk factor for stroke, and if you smoke and you don't have migraine, it's another risk factor for stroke. Sorry, smoke. So combined together, it does seem to provide an increased risk. So what does that mean? It just means really that it's what we call comorbid, where it means that you're more at risk in a proportion that has to be more than chance at developing stroke than or having a stroke rather than the general public. That's kind of what that means. And so essentially the main thing is there's more research is needed to understand how migraine affects smoking cessation. So how migraine affects giving up smoking and the challenges that that may bring. And also more research is needed to know why smoking appears to be more prevalent in people with migraine and what way that relationship goes. Is it that people who have migraine seem to be more likely to smoke, more at risk of becoming smokers, and people who smoke are more at risk of developing migraine. So we don't know what kind of relationship is and which way it goes, and maybe it's both. And that's same for a lot of things to do with migraine. It's kind of hard to it's just something that's more research is needed in so that we can support people. And nicotine and headache. We do know that nicotine is a substance that can trigger headache. And why is that? Because it's thought that the substance increases the sensitivity of your brain's pain receptors. So pain receptors are essentially nerve pathways in the brain and nerves and the nerve systems in your brain. And when nicotine is taken in, it can kind of wreak havoc, I suppose, with the nerves, and that is thought to cause headache in some cases. Bearing in mind that that's very closely related to migraine. So migraine is it's a condition where your brain is thought it's not fully understood, but its thinking is that it is a condition that is caused by a disorder of how the nerves work in the brain, and that in turn then causes increased sensitivity and patterns and is sensitive to triggers like nicotine or like other substances like caffeine and lots of other triggers that can happen, and that when you're exposed to them can trigger a migraine. So when we look at nicotine, when nicotine is shown that it can increase sensitivity of the nerves and in the brain, then we can see why, and cause a headache in not just a person who is predisposed to a headache, like a person who has been diagnosed with migraine or another headache disorder, but in anybody. So then also there's some relationship how nicotine can narrow the blood vessels, and that is also thought to possibly contribute to a headache caused by nicotine. Nicotine can reduce the effectiveness of pain medication, and that makes it harder to relieve pain. And we can understand again why that would be very problematic for a person who has been diagnosed or is trying to cope with a headache disorder. Frequent headaches are more likely to be experienced by smokers. And again, so we can see why there's lots of reasons why anyone who's a smoker is at risk of getting a headache, but why a person who lives with a headache disorder and might require some particular support from their GP or maybe their neurology team, if they're planning on giving up smoking and giving it the best shot, because just to give them the supports or give you the supports even that you can you have, so getting into nicotine and headache a little bit more and the withdrawal of it and why those supports are so important. And this is literally from the HSE here and the website there is on the next slide if you want to read more. But I just thought this was very relevant. So nicotine withdrawal, when you stop smoking can cause headaches. They usually stop in 3 to 4 weeks. That's a nicotine withdrawal nicotine withdrawal headache. Lost my page. There we go. A nicotine withdrawal headaches can come on, and they can happen in people. They don't always happen, but they can happen in people when the nicotine starts to leave the system. And that usually stops within 3 to 4 weeks. And so that's a nicotine withdrawal headache. And again, if you are living with a headache disorder, you could be sensitive to that. So that's, I suppose, a secondary headache, whereas we always refer to a headache disorder as a primary headache. such as cluster headache, migraine, non-daily or new persistent headache, they're primary headache disorders. So that essentially means that the headache is being caused from it's there's no other reason for the headache to be caused other than the disorder itself. Whereas with nicotine here, it's a headache that's being caused by the nicotine withdrawal. So it's another factor. So to help reduce headache in this scenario with nicotine withdrawal, the suggestion is to do regular physical activity. So already that's a tough one for someone who lives with migraine, because maybe in a lot of cases, or in some cases anyway, physical activity can be tough, can actually trigger headache. And while it is recommended to have regular exercise to actually reduce and to reduce your headache frequency and to increase your quality of life, it can be hard to get to that point, and it can be a tough thing for people to find the right type of exercise that will suit them, and something that supports, and something that isn't triggering. So it's important maybe to just seek some support with that, again through the GP, but also a physiotherapist can also be, we have a couple of physios that are known to us that we can help you with as well, to that have a special interest in headache, that might be able to provide some particular supports. And we actually had a talk done just the week before last by one of our physios, so that's available on our website, our YouTube page actually, and so that's just something to bear in mind. Eating regularly is the next point, and that is something that's also recommended, to have regular, migraine loves habit and loves routine, and eating a regular balanced diet is recommended. So that's kind of a good thing, because it's overlapping there. So it's something to bear in mind or seek support with, if something you struggle with, drinking enough water. And this is from the HSE website there as well, just using nicotine replacement therapy. So that is something just to speak to your GP about as well, if what would be best for you, or your pharmacist indeed, or neurologist, about getting the right one that might work for you and help you through this withdrawal period. And then some symptoms that can occur. So again, this is the HSE website there with all the information, goes into more detail. But some bits and pieces I just thought might be relevant. So cravings, and I won't go into it too much because Derek's going to take over shortly. But some things that are important. So it's a routine. If you are used to smoking, migraine loves routine, and it can be hard to change routine. So that's just something to bear in mind, that cravings can be hard, for many reasons, but just in relation to headache as well. Moods, irritability and anxiety. So there can be changes in your moods and can trigger anxiety when you begin to withdraw from nicotine. That can last up to 4 weeks. But we also know that when you live with a headache disorder, we mentioned stroke earlier, but another what's called a comorbidity, you can be predisposed to or more at risk of rather living with, you can be more at risk of mental health. Your mental health is more at risk when you live with head than the general public when you live with a headache disorder. So look, it's just something to just, if you feel that this is going to be something, or if you find that you're finding this hard, or have found it hard in the past, maybe if you tried to give up smoking, you can, again, it's just a good idea to just get all the support you can. Mentioned the headaches already, went through them. Sleep problems is listed as part of the withdrawal symptoms, and they're usually kind of can trigger or can become a problem for around 2 to 3 weeks before it settles, generally speaking. So sleep is really important for people who live with a headache disorder. Having a regular sleep pattern is something that's strongly recommended, and so having a period where your sleep might be a bit disrupted can, might be a problem for you as well, and it's something just to bear in mind. And again, we actually have a lovely talk on that on our YouTube page as well, that goes into sleep and measures that you can take to support your sleep hygiene and your sleep patterns as well. And I suppose it's just really about looking at it from a common sense point of view in terms of how what we know about nicotine withdrawal and what we know about migraine, and how we can kind of combine the knowledge in the absence of a lot of specific studies and research around migraine and cluster headache and smoking, and just try and give you the best shot. So that's just something to maybe prepare for. I have to and nausea. I just thought that was relevant as well, because a lot of people who live with a headache disorder also, as part of that, as we know, it's not just a headache, can live with very debilitating nausea, very debilitating dizziness, and that as well. So it's, I suppose, preparing for what might be coming on the road to overcoming smoking, and speaking with your GP and your other supports, and seeking other support to try and give you the kind of the best chance at being successful, and using a resource like someone with the supports that Derek can offer, the expertise and knowledge he has, and to support you through that as well. So kind of just about pulling out all the stops to support yourself. And it's not an easy thing to do, and it's a very commendable thing to try and take on. So just to maybe consider the timing as well, and just to make sure that you are giving yourself a lot of self-care and understanding through a time that might be hard, to deal with the sleep problems and all other things that come up, to look after yourself and to give yourself a break while you're trying to take on all that. With any concerns or anything you think that might be an issue, just make sure you have a chat with the relevant doctor. Maybe it's your neurologist, or it's just important as well to bear in mind that any new changes or symptoms to your headache, we always say should be assessed by your doctor. And even if it's just important that any changes are assessed, just to make sure that you're okay. So any sudden changes, or any changes in frequency, or any changes in intensity, even if you're kind of expecting it to a certain degree, because you're taking on, if presuming, say you were maybe starting a journey to quit smoking, it's important just that if something comes up that you're concerned about or you're not sure about, don't automatically put it down to that. If you have a problem with your headache, just make sure that you're always getting it, you're in good contact with your GP for any concerns at all or changes. And then just what we can offer then, I suppose I did touch on some of our YouTube videos, and there's a few resources there that might be good. Our info line signposting service is there. We offer listening support. It's usually me or Dee that you'll be talking to. So it's a chat, really, just to talk to one of us. Sometimes, and I mentioned we have a couple of physios and other specialists and other healthcare practitioners with special interest in headache. So like that, if maybe we could help you out if you want to seek any kind of support like that, or you're looking for information on neurologists or GPs, things like that. We also have self-management courses for headache disorder, that is all about it's run by one of our colleagues that's a psychotherapist, and it's just about different approaches to living with a headache disorder, and the pain that comes with it and the other factors that come with it. And then we also we have compassion focused therapy group, which is a session over a couple of weeks. It's run by a psychologist, facilitated by a psychologist rather, and again, some other approach to living with supporting you and living with a headache disorder. Every month we have 2 afternoon tea sessions, and because one of the big things with migraine and with headache disorders is that you really have to kind of have experienced it to understand it, really. So to provide that kind of level of peer support is just an opportunity for people who live with it, or maybe their loved ones, to get in touch with each other and share what that's been like for them, and with other people who understand.
For inviting me along today. My name is Derek Murphy. I work with Northside Partnership, and one of the roles I would do there is smoking cessation. So it was really interesting to hear about the interactions with nicotine and smoking and migraine. So having spoke to Naomi before and Deirdre, we thought it might be useful to just give a brief overview of the type of program that we would normally run for people who wish to give up smoking. As I said, I'm not going to claim that any of the information here is mine. It's all passed along to us through evidence-based training. They have compiled many different research studies from all over the world. So it's cross-cultural, it's age and gender. Like it works across many different cohorts of people. So the basic message that this HSE have compiled for us is that there is a 2.5 times more likely chance of being quit when you use a nicotine replacement product. There's a similar improvement in quitting chances if you use behavioral support, which is what we do. So if you combine both of them, the statistics would show that there's 5 times more likely to be quit at 28 days than you would be if you just tried it on your own with no plan and no support. Okay. So with that in mind, I'll just give you a quick overview of the course that we do, and hopefully it helps you understand what might be involved with quitting smoking and how achievable it is. Okay, so there on the right hand side you see a little just a graphic to explain the program. It's off the front of one of our books, and like running a 5K for the first time or whatever, you've got much better chance of succeeding if you make some sort of a plan and you put some practice in, and there's a strategy attached to what you're doing. So what we bring to the table is, one, the strategy. So we'll give you a way of working out a plan that's appropriate to you. It's patient or person-centered. I can give you things that other people have found useful, what we can recommend, but it's down to the individual as to how they structure their day on their quit attempt. The program usually runs across about 7 weeks, possibly up to 10, if depending on the group or the individual. So we would offer weekly support, which entails about an hour, 45 minutes to an hour, depending on availability, and that can be done in a group session, in a group environment, or one-to-one, and it can be done virtually or in person. So we do our best to meet the people where they're at, what's convenient for them. If you're working full time, might not be easy to take time off every week. So we have evening sessions, usually on a Tuesday evening, but that can be flexible as well, depending. And we can do them over Zoom as well. So what also comes as part of the service that the HSE are funding is nicotine replacement therapy. So that can be a number of weeks, sometimes between 6 and 10 weeks, depending on the plan that's been recommended. And the cost of that is provided free through one of our partner pharmacies. This can apply all over the country. It's not just necessarily to Northside Partnership. There are different partnerships and quit cessation advisors from the HSE all over the country. So it doesn't matter where you are, there's usually a local support of some description. What people bring to the service themselves is a willingness to, how would I say, to surrender to the program, to the idea that it is possible if you do. Like, people often ask me how many or what's the success rate, and I say, well, if you do exactly what's suggested, it's 100%. It's people who don't do what is suggested that don't necessarily make it to the end, and they don't normally stay, normally just drift off. But look, everybody, it's a step, and no matter what part of it that you engage with, it's a step towards a quit success. So commitment and consistency really is what people would need to bring, so that you show up every week, you do the suggested things. If there's some homework suggested to you, that you would do it. My experience is that the people that engage the most with the program are the people that have the most success. So I can't talk anybody into giving up cigarettes. That's not the way it works. So people come with a willingness to want to quit. And as you can see there, there's a few different main topics across each week, but I'll just go through them now. So week 1, Week one, as I said, it's very person-centered. So what we try to do is one of the main homeworks on week one is to keep some sort of a smoking diary, whether it be for a day or different parts of your day, or it's really the focus of the exercise is for each individual to identify their own smoking habits and patterns. So some people are heavy smokers in the evenings, some people smoke most in the mornings, whatever. Everybody's different. I've had one lady who smokes mostly in the bed in the morning before she gets up. So sometimes she says that she's there till 12 o'clock in the day because she's still smoking and she doesn't smoke much when she gets up. It's unusual, but smoking, it's an individual thing. And so that's why it's really important that we don't just give you a fixed program, that the program evolves around your own pattern and your own life. So I suppose the other side of that is then bringing smoking to the conscious as opposed to the unconscious. So anyone who's a habitual daily smoker should be usually able to identify with the idea that they could often have smoked cigarettes that they don't necessarily recall. Similar to the way you might drive. If you have something heavy on your mind, you might drive from one place to another and not really remember much about the journey. There's a lot of the behavior turns into unconscious automatic behaviors. So examples of that would be a lady who spoke to me before. She said she can't answer the phone without her cigarettes. It's an unconscious thing. People can't get into the car without the cigarettes. People who say they have a cigarette lit in the car after getting into the car before they even realize, so on and so forth. Everybody has these little triggers. They're just little rituals. But part of week one exercise is bringing those habits into the conscious. Asking yourself before each cigarette, do you want to have a cigarette? So it's just getting your mind ready for the quit attempt. We're nobody asking you in week 1, 2, or 3 even to quit a cigarette. It's just really getting you familiar with your own smoking habits so that you can actually construct a plan around them. Week 2 then is making your own plan. So that will be trying out some certain things. I'm going to try not smoke in the car. Okay, so what can I do to make that happen? I maybe don't bring the cigarettes with me when I'm going on a car trip. These are just little tests that people can do with the safety net of still being able to smoke before or after. It's to see, can I make it an hour? Can I make it 2 hours? Can I make it whatever? Can I do a certain routine that I normally would smoke without smoking? Such as people have suggested or told me before that they often automatically light a cigarette when the bus is coming. Some people have magical thinking about it, that if I light the cigarette, the bus will come because it's like Murphy's Law or something. So these are just some of the things. Can I wait for the bus without lighting the cigarette? Just to test to see what would happen. Then is to try and put some of that of your plan to test it out so that you don't just get to quit date and find out that your plan doesn't work, or that your distraction method that you're thinking of using to get you through a craving or a thought about smoking doesn't last. This just reminds me now that I didn't have it on a slide, but all the research that they have on smoking cravings or smoking thinking would say that it should only last about 5 minutes, 5 to 7 minutes maximum, if you just successfully distract yourself. All right, so it's just something to keep in mind. Week 3, then we discussed nicotine replacement products. That's NRT. They come in 2 forms really. There's a patch, which is a dermal delivery system or transdermal delivery system of nicotine. Just bear in mind that nicotine, the chemical, is the same chemical no matter what color it is or what shape it is. It's in a cigarette, it's in tobacco, it's in a pipe tobacco, it's in a patch. And then the rest of the products that we would normally combine with are oral products, which is either a gum, a spray, a little inhalator, a lozenge. I think that's all of them. And just to point out that nicotine is not absorbed in the intestine or in the stomach. It has to go through the skin. So even the oral products, they have to be absorbed within the mouth. So spraying them down your throat or chewing the gum incessantly and swallowing everything isn't going to get you nicotine into your blood. So it's just worth pointing that out. Some people would often say, oh, I've used them before. All I got was an upset stomach. They weren't using them properly. Week 4 is around withdrawal and stress. And Naomi was talking, made reference to this earlier on. We look at some of the stress and withdrawal that can be associated with giving up an addiction or a quit or smoking anyway. So some of the withdrawal that you would experience can be due to nicotine withdrawal, but some of it can be also just because you're changing your habit. And then the stress that's associated with that. We go through how stress is caused by nicotine withdrawal and how stress is caused by other things in our life, and how nicotine necessarily can't necessarily resolve the stress that's created from other aspects of our life, even though our brains have learned mistakenly that's what we do. So I'm stressed in work, I'll have a cigarette. It doesn't mean that the report doesn't have to be done or that your boss isn't disappointed with you or whatever, or you've too much work to do. The cigarette isn't going to help that, but you've learned somewhere along the way that cigarette helps with stress. It's really only helping with the craving for a cigarette, but we get into that. Coping strategies. Then we look at different coping strategies to around stress. In Northside Partnership, one of my colleagues can deliver mindfulness meditation classes, stress management classes. The reason I said that the program can last longer than 7 weeks is that we can often intersperse the course with an additional session, such as mindful meditation or stress management or just general education pieces. Some people look for an additional session around food, because there can be a replacement happen when people stop smoking. They start to eat all the wrong foods and so on. So we can look at that as well. And predominantly, the coping strategies revolves around what we call the 4Ds. It's distractions, distracting your mouth, distracting your hands, distracting your thinking, and distracting yourself. So some situations you can move yourself to a different location to get through a thought about smoking. Other times you can just do something with your hands. Other times distracting your mind, and other times distracting your mouth can help. Food and exercise, as I said, that can often happen. People will be curious about what happens if I start eating biscuits every night instead of smoking, all that kind of thing. So we can put some positive suggestions around types of food that would be more appropriate, and then maybe some additional bits of exercise that can help with interrupting your normal routine around smoking. Now, that's roughly what the program is, how the program runs. The majority of the program is based around an individual's desire to make a behavior change. And there's a particular model that is in the program around behavior change. And this is what we call a decisional balance. And people might have noticed it before, but it's very simply, what are the positives and the negatives of remaining the same, of staying as a smoker, of doing nothing about the habit? And then what are the positives and the negatives about making a change? And very often, this is where the success or the failure of a quit attempt can be based around, even though it looks fairly innocuous enough. But these are the thoughts that are going to happen on a daily basis during a quit attempt. This isn't worth it. I can't do it. All that kind of negative self-talk. So they're all around beliefs. So they would probably go into your category about what worries me about quitting. So it's going to cause me stress. So for migraine headache sufferers, they're going to think, is quitting going to cause me to have additional headaches that are going to interrupt my daily function, so on. So these are things that the more detail that you write into these boxes, it doesn't have to be on that page, like that's just a graphic, but the more detail that you make, that you decide for your decisional balance, and picture it like a seesaw. So at some point or other, the reasons for quitting are going to outweigh the reasons for not quitting at some point in everyone's life. Usually when you're younger, you're bulletproof and nothing's going to happen. But as we get older, we start to become more aware that there might be a health express train hurtling towards us with some bad news down the road. But as we get older, these are the sort of things that go into this decisional balance. And I would say, encourage anybody, the more, if you're going to do a course like this, the more that you put into that element of the decision for yourself, because when your rational brain is able to sit in a nice relaxed place and put down the reasons for staying or the reasons for quitting, it's going to be handy to have access to those reasons when you're in the height of a will I, won't I craving. The other element of the program that we discuss is a fairly well-known model of health, or that is used to describe health in recent years, is a biopsychosocial model. It's just it's just acknowledging the complex interplay of your social environment, the biological aspect of health, and the psychological aspect of health. Now, when applied to smoking cessation or smoking, the biological side of it would be the dopamine reward system that you get for actually having the cigarette. And in actual fact, having discussed this and done a bit of reading around it, the dopamine, you're getting the reward from your from the dopamine around a cigarette, usually within the first couple of seconds of either getting to the place where you smoke, so as in you're getting the dopamine reward before you've even lit a cigarette, or just straight after. And then we look at there's significant stress hormones obviously associated with not smoking or thinking you want to smoke but not doing it. So that's such as a quit attempt. Social aspect of it is around, I smoke with my friends, my identity is wrapped up with smoking. I am a smoker, I go with the smokers, I stand with the smokers, I spend time in the pub with the smokers, so on. There's a load of identity attached to smoking. So there's a fear, oh, do I have to stand over there on my own or whatever, separate to everybody else when they're smoking? So we do look at all of that side of it as well and discuss it within the course. And the psychological then is just acknowledging that a lot of the reason that people smoke or continue to smoke is around some sort of a reward system, some sort of an emotional state. I'm happy, I'm sad, I'm getting some sort of soothing. There's some sort of comfort in the smoking for me. So there's a psychological aspect of it. We look at all three of them. However, most of the research would show that the habit, the ritual, is all wrapped up in the psychological and the social side of it. So the biological is actually looked after by nicotine replacement. So it's interesting to say, if you are in the middle of a quit attempt and you are craving a cigarette, but you're also using nicotine, you're not craving nicotine. So then you can actually, you're better prepared to have a look at what it is that you're craving. Because if you think it's nicotine and you're taking a patch and you're chewing your gum, it's not nicotine that you're craving, it's something else. So it's something to do with your social situation or your psychological thought process. And what we tend to do is to look at people's beliefs around smoking and especially get them to write them down. So there's elements of CBT in it as well, where you would write out the trigger, write out the thought, write out the feeling attached to it, and so on. So like it's all evidence-based. There's loads of different theories that are come together to compile this course. It is a behavioral support. People can tough it out with willpower, and best of luck to them if they can do it. However, the willpower does come into play, but I always say willpower is kind of like a muscle. It gets tired, and you need a better strategy and a bit of a plan attached to it as well. So when you can't just rely on your willpower to get you through. How the course is delivered, then, as I mentioned to it earlier on, we in Northside Partnership provide group sessions. So within a group, people often play off each other. They give each other support, they give each other ideas, they give each other suggestions. There's a great bit of reflection and peer support in a group with the suggestions from each other from different people in the group. We can also do in one-to-one sessions. Some people don't enjoy the group. Some people prefer to just do one-to-ones. They can do that with myself or colleague or whatever part of the country they're in. There's a local cessation advisor available. You can usually find all the details on the HSE websites. Then we can do that either over the phone, as I said, in person or on Zoom. And in Northside Partnership, we also offer group and one-to-ones either online through Zoom or across the phone. We run programs all of the time, and I don't know, it seems that it does work. The evidence is there, and if anyone is struggling with giving up smoking, I give it a go. There's literally nothing to lose. It doesn't cost you anything other than your time and some commitment and consistency.